Good morning, class. Our topic for today is on osteomyelitis of the jaws. So, from history, there has been fossil evidence of bone infection. But earlier, the presence of pus was thought to be laudable pus. That means this was supposed to be helping in healing. The presence of pus was supposed to be helping in healing. Whereas it was in the 19th century that it was understood that the presence of pus is actually the presence of infection, and that this has to be evacuated in order to prevent the disease from progressing any further. And it was in the 20th century, after the advent of antibiotics, that the cases of osteomyelitis has considerably decreased over time. But presently, with the increased use of antibiotics, there has been resistance to these bacteria, and as a result, the cases of osteomyelitis is still increasing. Coming to the definition of osteomyelitis, in Greek, osteon means bone, myelos means marrow, and itis means inflammation. So osteomyelitis is actually inflammation of the bone marrow. Osteomyelitis may be defined as an inflammatory condition of bone that begins as an infection of the medullary cavity and spreads via the Haversian system to extend to involve the periosteum of the affected area. That is what is osteomyelitis. Now, there are certain predisposing factors to osteomyelitis. First is conditions that alter the host defense. Secondly, these are conditions that alter the vascularity of the bone. And third is the virulence of the organism. So first, coming to conditions that alter the host defense. So certain conditions like systemic diseases like diabetes mellitus, malnutrition, anemia, agranulocytosis, leukemia, drug abuse, chronic alcoholism, typhoid, sickle cell disease, all these actually alter the host defense, making it more susceptible for the person to get the disease. Conditions that alter vascularity of the bone are usually a irradiated bone. Apart from that, you have osteoporosis, Paget's disease, fibrous dysplasia, and even bone malignancies. Virulence of the organism is where the organism itself is a very fastidious organism and can spread the disease faster. Now, coming to etiology, the etiology is usually a odontogenic infection. Apart from that, you also have trauma, infections of the orofacial region, and infections that are derived by hematogenous route. The microbiology, the principal organism usually involved here is a Staph aureus. Less commonly is the beta hemolytic streptococci. Apart from that, you also have species like the Salmonella, then you have the Mycobacterium tuberculosis, Brucella. Very less common is the fungal osteomyelitis, which is usually caused by aspergillosis, blastomycosis, or histoplasmosis. Now, coming to the pathogenesis. Now, suppose there is a odontogenic infection. What usually happens is there is acute inflammation, which results in hyperemia and increase in the capillary permeability, as a result of which there is going to be edema. Now, tissue necrosis happens because of the proteolytic enzymes that are liberated by the bacterial organisms, and there is pus formation. So pus is usually a collection of the necrotic tissue and the dead remains of the bacteria. And that keeps accumulating, and because of the accumulation of the pus, there is increased intramedullary pressure. So the increasing intramedullary pressure results in vascular collapse, venous stasis, and ischemic bone formation. Now that pus, it keeps extending via the Haversian system to the region of the periosteum, which is the covering of the bone, as a result of which the blood supply to the mandible is disrupted, resulting in avascular infected bone that is formed. Now that avascular bone that is formed is called as the sequestrum. The necrotic bone that is formed is called as sequestrum. Now, where there is areas of bone destruction, there's also going to be areas of new bone deposition. So that area is called as the involucrum. The subperiosteal new bone that is formed is called as the involucrum. And these are the two very important terminologies you have to keep in mind here. What is a sequestrum and what is a involucrum? Coming to classification, the simplest classification is to classify osteomyelitis as a suppurative and a non-suppurative type. So suppurative is where you have the presence of pus, non-suppurative is where you have no pus formation. So in the suppurative type, there is the acute, chronic. The chronic is again of two types, which is primary and secondary, and then you have the infantile type of osteomyelitis. The non-suppurative, you have chronic sclerosing type of osteomyelitis, which is either focal sclerosing or diffuse sclerosing. Then you have the Gary's osteomyelitis. You have the radiation osteomyelitis, which is also called as the osteoradionecrosis. Apart from that, you have specific infective osteomyelitis, which is the tuberculous osteomyelitis, the syphilitic type of osteomyelitis, and the actinomycotic type of osteomyelitis. So in 1992, the Kuberge classification was as follows, which is divided it as acute forms and chronic forms. So acute suppurative or the non-suppurative kind of osteomyelitis is of three types again. You have the contagious focus, you have the progressive kind, and the hematogenous. The contagious focus is usually due to trauma, surgery, or even odontogenic infection. The progressive is usually due to burns, sinusitis, or vascular insufficiencies. And the hematogenous type is usually seen in the developing skeleton in children. The chronic form of osteomyelitis is the recurrent multifocal, the Gary's, the suppurative or non-suppurative, and you have the diffuse type. The recurrent multifocal is again seen in developing skeleton of children, and the Gary's is usually a unique proliferation of the subperiosteal reaction, which is again seen in the developing skeleton of young adults or even children. Suppurative and the non-suppurative kind, it usually arises because of the inadequately treated acute forms of the disease, systemic compromised patients, or even refractory forms which usually last for more than 6 months. Then you have diffuse sclerosing type, which is caused due to the fastidious organism or due to a compromised host defense mechanism. Now coming to Vibagul classification, where it is based on the pathogenesis of osteomyelitis. It is as follows: the hematogenous osteomyelitis, you have the osteomyelitis secondary to a contagious focus of infection, and you have osteomyelitis which is associated with or without a peripheral vascular disease. Next is the Ciani classification, the Ciani and Vibagul classification, which is based on the anatomic location. You have stage 1, 2, 3 and 4. Stage 1 is where you have the medullary form of osteomyelitis, where there is involvement of the medullary bone without involvement of the cortical bones. Then you have stage 2, which is of the superficial kind, where less than 2 cm of bony defect occurs without even cancellous bone involvement. Stage 3 is the localized form, where there is less than 2 cm of bone defect that is seen on a radiograph, and the defect does not appear to involve both the cortices. Stage 4 is where you have a diffuse kind of osteomyelitis, where the defect is less than 2 cm, causing pathological fracture, infection, and non-union. Now coming to the clinical features of the acute suppurative kind of osteomyelitis. Now the acute suppurative kind of osteomyelitis usually involves the maxilla or the mandible. Now why does osteomyelitis occur more commonly in the mandible than the maxilla? Because the midface is usually extensive in blood supply, and there are also a lot of collateral blood supply to the midface. Also, the nature of the bone is very porous, and there is abundant medullary spaces available. So as a result of which, in the maxilla, the disease is usually not very confined. So that becomes the reason why the mandible is usually more commonly affected in this case. The principal organism that usually occurs here is the Staph aureus. The clinical features include severe pain, malaise, fever, regional lymphadenopathy, elevated WBC count. The teeth involved in the area usually becomes loose or sore, and then you have paresthesia or anesthesia of the lip because of the involvement of the nerve, and then you have trismus. The chronic osteomyelitis is of two types. You have the primary and the secondary. The primary usually results from less virulent organisms, and the secondary usually occurs because the acute phase has not been effective enough in eliminating the disease. So that is why it goes into the secondary form of the chronic osteomyelitis. What are the clinical features here? So if the acute phase lasts for a month or longer, it goes into the chronic phase. And in the chronic phase, you can see that there is dull aching pain, there's minimal tenderness, there's non-healing bony and overlying soft tissue wounds, and these soft tissue wounds are usually indurated. You have intraoral or extraoral draining fistulae. You have thickened or wooden character of bone. There's enlargement of bone because of the subperiosteal new bone deposition. There can be pathological fractures. Sterile abscess is called as Brody's abscess, which is more common in long bones and it is rarer in the jaws. You have loose and sensitive teeth, and you can have paresthesia or anesthesia of the lip. So these are the draining sinuses seen extraorally. Now coming to investigation. Investigation involves histopathology, and this can include blood and aspirate culture. FNAC usually done for infants. Once you get reports of the blood and aspirate culture, you can test for antibiotic sensitivity. Now the samples of the culture can be taken from anywhere in the infected cavity wall, the sequestrum, granulation tissue, the involucrum. All these areas can be sent for as samples for culture. In the blood test, you would notice an increase in the WBC count, C-reactive protein and ESR. Coming to imaging, now when we talk about conventional radiographs like an IOP or an OPJ, now the problem with a conventional radiograph is that significant changes are seen on plain radiography only once the disease has progressed for at least 3 weeks. That means at least 30 to 60% demineralization of the bone should have occurred for significant changes to be seen on the plain radiographs. So the acute phase of the disease is usually not captured well on the plain radiograph. And the most important appearance that you see, the classic appearance that you see, is the moth-eaten kind of an appearance, where you can see areas of the sequestrum, that is a necrotic tissue, and surrounding areas of new bone deposition, which is called as the involucrum, giving rise to a moth-eaten kind of a pattern. Now ultrasonography is done in order to identify the presence of pus in the soft tissues. Isotope scans can be done, radioisotope scans, which is usually the technetium scan. Also the PET scans using radioisotopes like gallium or indium can also be done. These are most sensitive than the conventional radiographs. More sensitive would be the CT, and still more sensitive would be the MRIs, which is a very valuable tool in understanding the presence of the presence of disease as early in the acute phase. So this is just a flow chart to show you that conventional radiographs are least specific or least sensitive when compared to a CT or an MRI. So if you're very suspectant of a lesion, then you should go in for a better radiograph method, which is usually a MRI or a CT. Coming to the management can either be conservative or surgical. Conservative management usually involves supportive therapy and antimicrobials and analgesics. The antibiotic of choice is usually penicillin. So you start on empirical antibiotic therapy first, and after obtaining results of the culture and sensitivity, you can start your specific antibiotics. The regimen is as follows usually, where you put the patient on aqueous penicillin, which is 2 million units, IV every 4th hourly plus metronidazole, which is directed towards the anaerobic bacteria here, 500 mg every 6 hourly. Now, after the patient has improved 48 to 72 hours after, you can put the patient on oral penicillin. So, in regimen 2 for outpatients, you can put the patient on oral penicillin plus metronidazole, penicillin 2 grams and metronidazole 500 grams every 8th hourly for at least 2 to 4 weeks. If not, you can also put the patient on clindamycin 600 to 900 mg every 6 hourly IV, and then clindamycin 300 to 450 mg every 6th hourly. Now, coming to other conservative methods, it includes intra-arterial antibiotic therapy, local implantation of antibiotic saturated beads. Now, these are acrylic beads which usually contains antibiotics like tobramycin or gentamicin. It is applied locally so that it is more effective in providing antibiotic concentrated to that area alone. Then you have HBO therapy, which is the hyperbaric oxygen therapy, which involves giving 100% oxygen to a patient at 2.4 atmospheric pressure in a closed chamber, which can either be a multi-place chamber or a monoplace chamber, and this is done in order to remove any kind of tissue necrosis caused by the anaerobic organisms. Now, surgical management, it involves various modalities. Of this, one is incision and drainage. So, incision and drainage, depending upon the location, can be done either intraorally or extraorally. If the patient is systemically compromised or has signs of toxemia, then you would want to postpone the procedure at least 2 to 3 days after you have put the patient on IV antibiotics. Of course, if the causative factor is a tooth, so the offending tooth might need to be extracted. Third would be debridement. Following incision and drainage, you would want to debride the area with either hydrogen peroxide or saline. Decortication. Decortication is a method that was advocated by Obvigezer, in which there is, which includes the removal of the infected lateral and the inferior cortical plates of the bone 1 to 2 mm beyond the area of involvement, so as to gain an access into the medullary cavity. Now, this helps in removal of the dead necrotic matter inside and also helps in better vascularization of the area. So, this involves removal of the lateral and the inferior cortical plates of bone. Now, coming to sequestrectomy. Sequestrectomy is the procedure where you remove the sequestrum. If it is small and accessible, you can do it intraorally. If not, if it is large and inaccessible, then you would have to go in for an extraoral approach. Saucerization. Saucerization is a method where the margins of necrotic bone are excised in order to permit visualization and removal of the formed sequestra. That is, in order to aid in removal of the sequestra. So, this also avoids dead space formation. Now, coming to continuous or intermittent indwelling closed catheter irrigation. So, in this, after sequestrectomy or cortication, what you can do is a nasogastric tube, 2 nasogastric tubes, which are 3 to 4 millimeters in diameter and 6 to 10 inches long, can be placed at the area of the lesion and at the area of infection, and one tube is attached to a low pressure suction in order to allow drainage of the pus, and the other one is kept patent in order to allow irrigation by either using saline or a local antibiotic. This is the picture where you can see 2 nasogastric tubes, one which is attached to a suction device, and through the other one you can continuously irrigate with a saline or any kind of a antibiotic solution. Trephination. Trephination is the process where small burr holes or small bony holes are made in order to decompress the medullary compartment. Then if your lesion is very extensive, then you would want to go in for a resection. A resection is where you have to remove that part of the mandible or the maxilla which has been involved. This can be hemimandibulectomy, where even one half of the mandible can be removed if the infection has progressed very extensively. So once there is a resection, there's always immediate reconstruction of bone so as to prevent any kind of pathological fracture, to prevent any kind of jaw deformity, and to provide attachment to the soft tissues. Now the different types of osteomyelitis shall be dealt in the next class. Thank you.